Yeah, thank you, Salil. At the outset, I would like to thank Salil for inviting me here. And in the next 7 minutes, we are going to try and see what are the intraoperative problems which happen with silicone oil or gas. Mind you, there are not too many intraoperative problems directly related to the oil or gas, as long as you have relieved the traction, as the way Bhushan has said, before the surgery. If you have silicone oil, the most common thing which happens is oil coming into the anterior chamber. And that is the biggest bugbear for all of us. All of us use oil, and the next day, in the intraoperatively, we see that it's in the anterior chamber. You can have oil in the subretinal space, suprachoroidal silicone oil, intraoperative optical problems because of oil problems because of overfill or underfill, bleeding under silicone oil, or intraoperative operative problems because of silicone or gas adhering to the posterior surface of the IOL. As I said, the most common thing is oil in the anterior chamber. This can happen in patients who are aphakic. Pseudophakic eyes is a large open PC lens, the normal crystalline lens with zonular damage which has happened, overfill with a high posterior chamber pressure, or excessive globe manipulations after putting in the oil. And one must avoid all this once the oil is inside the eye. The prevention is very important in these patients. At the stage of vitrectomy or at the stage of fluid gas exchange, if you find that there is a danger of anything coming into the anterior chamber, it's best to fill the anterior chamber with a viscoelastic, preferably sodium hyaluronate. That's what I do if I feel that this is a pseudophakic patient and there is maybe zonular dialysis, maybe the gas or the oil is going to migrate out, up. I just fill the anterior chamber up, make it taut with the sodium hyaluronate, and then usually at the end of surgery, we remove that sodium hyaluronate off, and this usually avoids the oil. You also have to avoid an overfill, because when you have an overfill, what happens is the posterior chamber pressure increases, and at that time the oil leaks from the posterior chamber up. Now, in case you are aphakic oil patients, then what you can do is you can go into the small Japanese anisotromy, the inferior 6 o'clock anisotromy that you have done, and inject a little bit of saline into the anterior chamber. Once you do that, the oil naturally migrates to behind the iris and usually remains there. However, when you are doing this maneuver, you have to remember that the eye has to be soft. If the eye is hard at this stage, instead of the oil going down, your fluid itself will go down and the oil will still remain up. Again, if this happens in pseudophakic eyes, then you will really have a problem, because if the oil is there in the anterior chamber, you don't know what to do. So the ideal thing would be to remove all the oil from the posterior chamber and the anterior chamber, remove it completely, inject viscoelastic in the anterior chamber, and then again fill the oil from behind. However, sometimes what one can do is make two paracenteses, infuse visco from one side and depress the second paracentesis a little bit so that the oil comes out from the second paracentesis. But when you have done that, this is a very important thing to remember. Sometimes the oil gets trapped in between the lens or the IOL and the iris. And one must remove this oil off, because otherwise you feel at the end of your surgery, my oil is perfectly behind in the posterior chamber. The next day the oil comes up. And this oil which is there, which is trapped in between the IOL and the iris, can also sometimes cause a pupillary block glaucoma, which is very, very difficult to relieve, and you might need to do a resurgery for this. Oil in the subretinal space, again, this is not a very common complication as long as you have adhered to the principles of vitreoretinal surgery, and that is you have to relieve all the traction. If there is unrelieved traction, then you would have oil migrating into the subretinal space. Again, you have to avoid excessive manipulation of the retina under oil. If you do that, maybe sometimes a small bubble of oil does go down. Now, this happens when you increase your infusion pressure to flatten the retina too much. Because when you have air in the posterior chamber, the air will naturally, it's got a very high surface tension, and it will flatten up the retina. And then when you put oil, the retina again starts getting raised up and your oil starts migrating underneath. So the important points to remember in this case to avoid oil in the subretinal space is to have unrelieved traction, and you avoid the excessive manipulation of retina under oil, and you must see that it is flattened completely. Again, as I said, you have to relieve all tractions, do the relaxing retinotomy. Suprachoroidal space, very, very rare, but if it happens, it's a very devastating complication, and one must avoid it by checking that the infusion cannula is inside in the vitreous cavity before you do it. Bleed under oil, as I think has already been covered to some extent by Sharat. If it's a small bleed, you can leave it. If it's a large bleed, at the end of surgery also, spend 30 more minutes, remove that oil, stop the bleed, and then put oil back. Because otherwise you will have to do that 3 or 4 days later. Again, this is another very important problem which happens, that is the 23 or 25 gauge sclerotomies. I have found that there is a leakage of oil through that wound. And very often, if I put silicone oil inside the eye, I feel like taking a suture on that 23 gauge sclerotomy. If I put gas inside the eye, the sclerotomy shuts very, very well. Again, when you are doing oil removal, you may leave some oil behind, and in order to see to it, you need to do multiple oil air fluid exchanges. Go into the eye, see that in the periphery there is no emulsified oil which is adherent to the retina, and you have to remove all that. Sometimes you need to remove Denseron, because even if you may not be putting Denseron, I had a couple of times a patient who had put Denseron elsewhere and came to me. Now, Denseron, remember, is heavier than water, so it will settle down. So you need to remove it the same way you remove PFCL, and that is with active suction, and the last bubble has to be removed from the optic disc. When you go to complications of fluid gas exchange and of gas, one can have break extensions, then one can have subretinal air or gas where the traction is not relieved. And in these cases, one must remove the membranes and do the retinotomy. Gas in anterior chamber is much less of a problem than oil in the anterior chamber, because eventually gas is going to be absorbed. But one must see to it that your gas fill is proper in these patients. Again, you have another complication of gas or FG is that you have small bubbles of condensation over the IOL. And as Sunil said, he likes to wipe it with the light pipe. What I prefer to do is take a viscoelastic, put a small 25 gauge or 27 gauge cannula, go into the side to the sclerotomy opening, and just make a small bubble over there which is just adherent to the cannula, and just touch that bubble to the IOL. The bubble will spread because of the surface tension and take care of this problem. Then you can have a gas mixture. So some of us inject pure gas, others inject a non-expansile mixture. What I typically do is I inject a non-expansile mixture. If I'm using SF6, I take 2 cc of the gas and I take 10 cc of the fill it to 10 cc, and then I inject it through the infusion port. And at the end, I leave around 2 cc's in that gas syringe, and I remove all the sclerotomies. Because at the end, if you have a slight hypotony, that 1 or 2 cc with a 30, you fit a 30 gauge needle on it, and then if you have hypotony, you can always inject that gas back into the cavity to fill up the gas. The other important thing is you can have a displacement of intraocular lens implant with the gas, especially that of an iris claw lens, because the claw lens is very mobile, and the claw lens, even if you put a posterior chamber claw lens, that posterior chamber claw lens can occlude the pupil and it can come up and get stuck to the corneal end. So one must be careful about that. Complications of PFCL, a lot of them have been already dealt with. So the most important thing is to avoid the small bubble formation. You have to inject PFCL on the disc, or you have to reduce or stop the inflow. One can have subretinal PFCL, or in any case, you have to remove all the PFCL. If at the end of surgery you find there's a small bubble over there, go in and remove it. You can have retinal slippage during PFCL gas exchange, and that's why you prefer PFCL silicone oil exchange. Remember, in order to avoid the subretinal PFCL, one must always fill up the PFCL up to the level of the break, but do not go beyond the break, especially if you have formation of small bubbles over there. Then subretinal dyes. When you inject dye, remember you're injecting the dye directly on the macula, or you're injecting it directly on the optic disc or very close to the retina. One must remember to always use a Luer lock syringe for doing that, because sometimes if you use a syringe which is non-Luer locked and your cannula gets blocked, that cannula is going to go out the way we saw in the OPL detachable instruments. Your cannula is going to get detached and going to cause iatrogenic macular hole. If you feel that you have a large hole with a large fluid, what you can sometimes do is put a small bubble of viscoelastic or a PFCL over the hole to prevent the migration in the subretinal space. This is what we could manage in the 8 minutes. Thank you very much.